All right, so my name is Hamza Ansari, and I am currently a second year GP registrar at Royal Shrewsbury Hospital. Um, I will be presenting a audit that we had done. I have a special interest in orthopedic surgery. I'll be presenting an audit that we had, a closed loop audit that we had done on fascia iliaca block and specifically hip fractures. The clinical lead for this was Mr. Ford, who's a trauma and orthopedic surgeon at the Robert Jones Agnes Hunt Hospital, and he also works at the Royal Shrewsbury Hospital. These are my colleagues who helped me in collecting all the data and analyzing the data. And I'm Dr. Hamza Ansari. I'll be presenting it. As I said, I'm a second year GP registrar with a special interest in orthopedic surgery. Now, the background essentially, what is the significance of a fascia iliaca block? What it does is it provides pain relief in those patients who especially have radiologic evidence of a fracture of the hip, a fracture of the femur, or a dislocation of a hip prosthesis. And this causes extreme amounts of pain. So the fascial iliaca block, what it does is provides local anesthesia directly to the nerves, and this way, preoperatively, you have very good pain control, according to our national hip fracture database in the UK. And postoperatively, it reduces the amount of pain the patients experience, and this also correlates to the fact that it reduces hospital stay for patients. Um, the main thing that we've noticed in the perioperative period for hip fracture patients specifically is that the pain control is quite severe. So they take a lot of morphine, a lot of codeine, tramadol preoperatively, and then postoperatively they still require uh, pain control, and this leads to constipation. You know, they're not opening their bowels. They're very they're not able to start walking again, which we encourage all patients postoperatively to do, and this then extends their hospital stay, and by extending their hospital stay, it then leads to further complications that may occur. For example, hospital-acquired pneumonia or pulmonary embolism. Um, now, how fascial iliac block is performed? There are two methods. In our particular trust, we use the two-pop method. So, as you can see on this diagram here, to your right, you have the fascia iliaca and you have the fascia lata, the two fascias that are pop. So, uh, the first thing is you have to look at the geographical location. So the anterior superior iliac spine and the pubic tubercle, you create a line between the two. Then you divide those into thirds. You find the lateral third and the medial two thirds, the point of intersection. Then go 1 centimeter below that. Palpate. Make sure you're not going into the artery, but you're lateral to the femoral artery, and then you insert the needle, the blunt needle. So you'll feel two pops. So the first pop is you're piercing the fascia lata. The second pop is you're piercing the fascia iliaca. And then you go into the fascia iliaca compartment, which is a potential compartment containing the lateral femoral cutaneous nerve and the femoral nerve. And these are the two nerves that provide a sensation to that area of the thigh, and which cause most pain when there is a fracture of the hip or femoral fracture. Um, and this usually provides about 8 hours of uh, anesthesia before the operation, preoperatively, and we try to do operations about uh, within 33 hours of being admitted to A&E. Um, now, next, we have a standard that we use, and so this is a standard for our trust. So anyone who's coming in with radiologic evidence of a fracture of the hip, fracture of the femur, or dislocation of their hip prosthesis, they should receive a fascia iliac block. And in particular, this audit that I had led, this quality improvement project, was specifically for those patients who've had a fracture of the hip. Now, the aim was to first assess if fascia iliaca block was being offered to patients, if it was being administered once being offered, and if that was being documented in the documents, and who was administering the fascia iliaca block. So we looked at patients in the trauma and orthopedic ward at the Royal Shrewsbury Hospital between 3rd of September and 25th of September 2020. We reviewed the case notes retrospectively. We checked was there documentation of the fib being given, of the fascial iliac block being given. If the patient declined, was this recorded? If there was a contraindication to giving the block, for example, any allergy to anesthesia or any adverse reaction, and was this being recorded? The results showed that of the 27 patients we analyzed, 25 of them were offered the fascial iliac block, 22 were actually given the block, and 23 did not receive it because there was a contraindication, and this was also recorded. Now, there was no record of whether they were given the block or whether they were offered the block. And further analysis showed that 90% of the fascial iliac block were administered by doctors in A&E, accident and emergency, and 10% were actually administered by the trauma and orthopedic on-call team. Now, when we compare this to, as I mentioned, this is a closed loop audit. So when we compared this to the first cycle that we had done, which was during 10th of February to the 22nd of February 2020, we had noticed that 48% of the patients had received a fascia iliac block, and 52% had not received, and there was no documentation. Then, between February and September, we had an intervention where we did another national audit, a hip fracture pathway audit, which was essentially to assess are patients who are coming in with hip fractures and who have radiologic evidence of a hip fracture, are they being given adequate pain control preoperatively, and are they being given adequate pain control postoperatively? So when we audited this, we found that fascial iliac block was not being given in a timely manner in the A&E setting. So we basically did local education of making sure that the staff was aware of how to give a fascial iliac block, and that they're aware we are meant to give it as per the Royal College of Emergency Medicine guidelines. Then we did the second cycle, which was in September, and we found, and this was closing the loop, the audit loop, and we found that 81% of the patients received a fascial iliac block. Only 19% didn't receive, and that was because they had a contraindication or they refused the block themselves. Now, the key feature here is that we have a lot of dementia patients who come to the Royal Shrewsbury Hospital. The average age is about 95 of our patients who come in with a fracture of the hip. According to the Royal College of Surgeons, even dementia patients, they need to have a fascial iliac block, even though they're less likely to feel pain, but they need to have a fascial iliac block as per our guidelines. So this 19% does not, the 81% who did receive it, it also includes dementia patients. So the main points from this audit, which we can then generalize to other trusts as well, is that one, you need to have proper documentation of providing anesthesia or providing the fascial iliac block in all patients in the hip fracture pathway, especially as per your hospital protocol. It is the responsibility of the trauma and orthopedic team on call to take a proper handover from the doctors in accident and from A&E, and make sure, the first question should be, has adequate pain control been given? And if so, what was it? Was it morphine? Was it tramadol? Was it cocodamol? Or did we actually give fascial iliac block as per the Royal College of Emergency Medicine guidelines? Another thing that can be proactive for all departments is have a questionnaire and induction for any of the staff that are coming in. And are they aware of the local guidelines for fascial iliac block? Are they aware of how to perform a fascial iliac block? Do they need any training or any extra training? These are all important ways of, important methods of ensuring that your staff is, or your staff is aware of how to administer pain control and fascial iliac block specifically. The final thing that we found, which was very important and helped improve quite a lot in ensuring that all patients received adequate pain control, is that in the trauma meetings, in the MDT meetings that orthopedic teams have in the morning, it is important to have. I mean, not only should it be in the hip fracture pathway, but also it's important for consultants in the trauma meetings to ensure and double check with the staff, was a fascia iliaca block given, was pain control given, because our main goal in orthopedics is to ensure that patients who are coming in with a hip fracture, which is super painful, to ensure that they have adequate pain control. The reason we're doing hip replacements, or we're partial hip replacements or full hip replacements, is to reduce pain for the patient. And pain reduction should begin from the point that they come into the hospital. So not only should it be the junior doctors and middle grade doctors, but also the consultants who should ensure, um, and especially in MDT meetings, was the patient given adequate pain control? And this way, we're ensuring that they're pain free throughout their stay in hospital until they get the operation and the preoperative period. And we ensure that they experience less pain in the postoperative period, so that they're able to mobilize much quicker and and get onto the road, or get on their way to the road to recovery. And with that, I just wanted to present a quick audit that we had done, a closed loop audit. Um, at this point, if you have any questions, I'm more than happy to entertain.